You mentioned about the various treatment options like mycophenolate mofetil and steroids, etc. Um, is that something that patients need to take on a long term? And what if these medicines don't work that well? Are there other options?
Yeah. See, as I told you, lupus is, you cannot compare apples, grapes and oranges. So, lupus patient is, some of them are like apples, some of them are like grapes, some of them are like oranges. So, all these three fruits you eat in a different way. So, similarly every lupus patient is different. For example, every patient requires one drug called hydroxychloroquine, HCQ. That is a common drug which is very effective in the treatment of lupus, and most of the lupus patient, unless somebody is allergic or has long term side effect, has to take it or take it. That is extremely important drug. But other drugs, which one to give depends on which system is involved. For example, if somebody has a kidney or brain involvement, you need to act immediately, otherwise it will cause kidney failure or seizures or cerebrovascular accidents or stroke. So, those cases you require drugs which are act effective very immediately, very fast. The drugs which act very fast are steroids. They start acting in 1 or 2 days. So, steroids are very effective in the early phases, it acts very fast, but the problem with steroids is if you give it for very long time at a very high doses, it can be harmful. So, steroids are like bridges. What does bridge mean? For example, other drugs like mycophenolate, rasathioprine or tacrolimus, which have different mechanism of action, they take time to act. They take 2 weeks or 3 weeks or 1 month or 2 months to act. So, we need to give a drug which can act immediately and till the mycophenolate starts acting. When mycophenolate start act, it will start acting after 1 month. So, during that period you give steroids and then slowly start mycophenolate. By the time mycophenolate starts acting in 1 or 2 months, taper steroids, and thankfully within 1 year more than 95% of the lupus patients are able to come down to very low of steroids, and some of them 70 to 80% of them are eventually able to stop steroids also.
Doctor, I have seen patients like with my own eyes tapering their steroid doses like no one's business. When they have pain they increase, when they don't have they stop.
So the biggest thing with lupus, as I told you, lupus is, see, for example, rheumatoid arthritis, you have pain, you have something identifiable. In lupus it is not like that. Lupus you have so many manifestations going on. It is impossible for somebody who is not very well trained in lupus to understand how to treat them, because lupus is not as simple as it looks. You have to look at the total count, you have to look at how your proteinuria is, how your lung function is, how your other organs are functioning, and then only you titrate the drugs. So, it is not at all advisable to taper the drugs by self. So, you have to go to a rheumatologist, and with his advice or her advice you have to slowly come down on drugs and trust him for all your management.
Doctor, in 2016, after the diagnosis of my nephritis, you introduced me to this term called biologics, and you said that we'll be putting you on rituximab infusions. So, how often is that given to patients and how is its efficacy?
See, in lupus, if you look at the entire cohort of lupus, out of 100 patients, 90% of them, 92% of them are able to be, they respond to mycophenolate or tacrolimus or cyclophosphamide or etc. etc. But there are certain subsets of patients who are not able to mycophenolate, who are not able to optimally on, like you had abdominal pain. You had abdominal pain, you had diarrhea issues with higher dose of mycophenolate mofetil. So, nausea, vomiting. So, some of them are not able to tolerate mycophenolate on optimal doses, or some of them do not respond to mycophenolate. It is not that mycophenolate is effective in everyone. Mycophenolate is effective in 80 to 85% of them, another 10-15% require something more. Before 2010, there was nothing more. Thankfully, now we have belimumab, we have rituximab, now we have obinutuzumab. There are newer drugs coming up, and interferon therapies are coming up. So, there are a lot of new drugs coming up in lupus management. That is a very good sign. These patients, 10 to 15% of severe lupus disease patients, they require these drugs like rituximab. This is not that it is required for everybody, but yes, in subset of patients who are resistant to other therapies, these drugs are extremely efficacious. And that is why I am telling, if one drug is not responding, do not get disheartened. If you are having a side effect to one drug, do not get disheartened. If you are having a side effect to one drug, go and tell to the doctor rather than stopping the drug or consulting somebody else or taking the advice of internet or Google. Do not do that. That will be the biggest mistake somebody can commit. Always go to the doctor and have an open discussion. Doctor, I am not able to tolerate this drug. What should I do further? And most of the doctors, not all the most, there may be few exceptions, but most of them will listen to you, do whatever is necessary, and change your drug. And I am sure a rheumatologist who is trained in lupus will definitely be able to offer you that this drug is not working. Yes, these are the options we have, and there are drugs in lupus currently. Based on each patient's manifestations, socio-economic considerations, we can always find a suitable drug for every patient.
On this note, I'd like to invite everyone for the Lupus Day event that's happening here at Kochi. There'll also be a blended event that will be happening online. So we are hoping to have maximum participation from patients, their families and their friends and the support system. Thank you, Doctor.
Thank you.